Clean out the stomach, very often that is something that needs to be done after somebody has ingested something they're not supposed to, or like they've overdosed. To diagnose GI disorders, to administer medications and feedings, to treat an obstruction, to compress a bleeding site, and to aspirate gastric content for analysis. So these are all the different reasons that we put a tube down into the esophagus. And we have many different kinds of tubes that we use. Okay, gastric tubes, Levine, and some. And then we have enteric tubes. Excuse me. The Levine is a single lumen and is connected to low intermittent suction. That means 30 to 40 milligrams of mercury are put on the suction machine, and we use it intermittently. We never use continuous suctions with the Levine. The end of the Levine, there is a small opening to create the suction, and if it were continuous, you have the risk of it adhering to the wall of the stomach or the wall of the esophagus, depending on where you put it, which hopefully to the stomach, and actually causing erosion at that site because of the continuous suction. So that's why we do it intermittently, so that if it has adhered to the stomach wall, when the suction is released, it would pop it off of there and hopefully would not breathe it.
What is the difference when you give a feeding tube to the nose or, you know, like what would be?
Again, hold that thought. Okay. A sump is a radio-opaque tube, which means we're going to see it on an X-ray, which is one of the reasons it's used, because you can definitely tell where it is. It has multiple lumens. The inner smaller lumen vents the large suction drainage tube to the atmosphere, so it prevents that tube from getting stuck to the wall of the stomach. Usually we use it on lower pressure at around 25 milligrams of mercury. Because it is a double lumen tube, it can be used to lavage the tube to maintain patency, and it's used again for suctioning. Enteric tubes, we have many of those too, nasogastric, nasoduodenal, or nasojejunal, and these are used for feeding. The tube is placed in the nose, and it finds its way where it wants to go. Let's see where I'm going. Oh, right in front. Okay. So in terms of the enteric tube, the doctor's going to tell you that he wants a nasogastric tube, a nasoduodenal tube, or a nasal jejunal tube. And these are things that are placed by the nursing staff, not by the doctor. Right? So how do you place a tube? Anybody ever place one?
They insert,
I'm going to smack you yet.
they insert this kind of clamp thing, like the same one they use for the pelvic exam, kind of like that. And they put it in your throat, and then they shove the tube down. Or they put some KY, if it's going to go through the nose, and they shove it up into the nose, through the throat, and down into the stomach.
Okay, great. So how do we?
I've seen it
Okay.
intubate like a
Put a
thousand
gag
times.
on it.
I've seen it done so many times.
Okay. So you're just going to go into a patient's room and just start doing all of that?
No, the doctor
Oh,
does
good.
all that.
No, the doctor does not.
does.
This is a nursing function, absolutely. So how are we going to do this? You have a doctor's order to place a nasogastric tube. What are you going to do?
Tilt the head back.
No, you're gonna find first, you're gonna find
You're
out
gonna
what
find
type of, you're gonna talk to the patient.
Thank you. The back of the room. You don't have to actually get consent because it's not something that requires a consent signature. But you do have to talk to the patient, assuming that they're awake and alert. You have to talk to the patient and tell them what the procedure is, what you're going to do, how you're going to do it, why you're going to do it, what is the purpose of this, and hopefully they're going to be cooperative. Because let me tell you, if somebody comes at you and starts shoving a tube up your nose, it's not the most comfortable procedure in the world. And you do need a certain amount of patient cooperation to achieve it. So first we talk to our patient, we educate them. Next, after we've actually gathered our equipment, hopefully we've gathered everything at the bedside, next thing I'm going to do is I'm going to inspect the nares to identify which pathway, because most of us do not have an exact medial septum, and one nair is larger than the other. And I'm certainly going to want to try to go to the one that's larger, because it's going to make it easier to pass. All right? Your patient is going to be sat upright. You never want to do this with the patient in a semi-parallel or lying down, because you're going to have a really hard time passing this tube. Okay? You're going to want to give your patient a towel, because sometimes they start to salivate and spit up a little bit as you're trying to pass the tube past the gag reflex. Okay? And you're going to need a cup of water, because you're going to need that patient to swallow during the procedure. And you're going to have educated the patient about all of these things that you're going to do. Next is, who said measure? Okay, so how do you measure for the tube placement?
From the nose to the belly button.
While we're here.
We measured from the nose to the ear and then to the sternum.
Nose to the ear to the sternum, is that correct? Anybody want to say anything else?
Ear, nose, and belly button.
Okay.
To the-
Okay. Anybody else?
X-ray.
Well, that's afterwards. Okay. It is tip of the nose to the ear lobe, the ear lobe to the sternum, and you want to add 6 inches. Okay? Okay. Yes, you did have it right. Okay? But it's going to say not just the ear, it actually is to the ear lobe, okay, because that is the pathway. The pathway is slightly different if you go to the top of the ear. You actually change the measurement. So no, tip of the nose, tip of the ear lobe, down to the xiphoid process, and you add 6 inches. Okay? Now, the next step is still in the measurement phase. You want to put a marker on your tube. So you take a little piece of tape and put it at that marker. So when you're inserting the tube, you know where that end of that tube should be at the tip of the nose. So you put a little piece of tape around it. Then you have that patient again. You're sitting him upright, so now they know what's going to happen. You're going to lubricate. Somebody over here said lubricate the heck out of it. You want to put a water-soluble gel to make sure that the passage makes it easier. Okay? You're going to start to insert it through the nose. You're going to have the patient do some deep breathing, because it is an uncomfortable procedure. And as they start to swallow and gag a little bit, that's when you want to tell them, because you've passed beyond the nasopharynx, you tell them to start sipping the water. Not just guzzling it, but sipping it, so that as they're swallowing, you're watching them swallow the water. That's when you push the tube, as they're swallowing, because that means that their esophagus is at its most open, and it's going to go beyond that cough reflex and gag reflex, and you keep inserting it till you have reached the measure that you placed on the tube. You then secure it. What's next?
Test it.
How do we test for confirmation that it is where you want it to go? Okay, one. Okay.
You listen.
So we have some presumptive confirmation. Presumptive is listen. What am I listening to?
A bubble.
A gush sound.
A gush.
I know you listen. That's all
Okay.
I know. I don't know
She's
what
just
they're
going to stand there and
listening
listen.
With a stethoscope.
for. You're listening to something, I'm not sure what.
Okay, well, listen to the stethoscope. Where am I listening for?
Bowel
See if it's in
sounds?
that place.
No,
Gurgling of the air.
yeah, you push air on it. and
You
then
have to push air in it. You take a 30 cc syringe, you fill it with air. You put your stethoscope, where is the stomach supposed to be? Right in your epigastric area. Okay, you give a quick plunge and you should hear a big whoosh sound. Does that mean it's absolutely where you want it?
No.
No, that is a presumptive confirmation of placement. Aspirating gastric content is also a presumptive, because maybe you're further down, maybe you're in the duodenum and I want to be in the stomach. Maybe you're coiled up in the esophagus and you've got residual food up there. You have no idea. The only way you can absolutely confirm is by doing an x-ray. So you should not push anything into that tube until you have x-ray confirmation. Okay? And another test that people will still do if they're kind of not sure that it's actually in the esophagus at all is you take the end of the tube and you dip it in water. If you see bubbles, you're definitely not in the esophagus. You're in the lungs, because air's coming out. And usually you'll know because your patient's making all sorts of facial expressions, but if they're comatose, you may not get anything.